I show 33 participants in that thing, so.
Good.
All right, it looks like we have everyone logged on, so if you want to start, you can.
Okay, thank you very much. My name is Van Williams, and you may have occasionally seen me here as a co-host and also a presenter at Lifelong Learning. And my job here is relatively brief. I want to first say congratulations and thanks to Dick Phelan, the founder of Lifelong Learning here at Gray Oaks. And actually, I remember joining in on some of his organization thing we was over at the Audubon, the earlier place. So it was really great to work with Dick, and he did such a great job of recruiting speakers and making sure that people knew about lifelong learning and recognized it as an exciting way to expand our horizons here in Gray Oaks. However, I'm also very pleased to say that we now have a successor to Dick, a person very able in all respects. He is a 35-year veteran of higher education, a former president of DeVry University for more years than he may care to admit right now. I actually had the privilege of serving on his advisory council for a while, and so I got to know Dave pretty well. Unfortunately, my golf game deteriorated while his got better after he retired. So, but he is a very, very active member of the Lifelong Learning Group. He's presented several times, and he's got a wonderful track record in higher education and other forms of community service, in addition to running his own business consulting on leadership issues. So I'm going to formally hand the baton off to Dave. I suspect there will be times where he might be introducing me for a presentation and maybe even vice versa. But Dave, you're now stage setter. You got the ball. Run with it.
Right. Thanks a lot, Van. Appreciate it. Van, will be hearing from him in February. He'll be giving us a presentation, as he does pretty much every year, this year on growth in Collier County. And I just want to echo salute to Dick Phelan, our founding father with the Lifelong Learning Program. His steady hand over the years has really brought a ton of value added learning content to Gray Oaks members, and we're very grateful for that, Dick. He may even be on the line up there in Chicago today. Dick put a turnkey operation together, handed it over to me last month, saying that all of the lineup for this year is all set and booked and ready to go. So all we got to do is execute. I'll talk more about some of the future presentations at the end. But right now, let's get going on today. Certainly, there's been no topic more all-consuming than the coronavirus in our lives over the last 9 months. So it only made sense to have an established medical professional come to speak to us on that topic. And that's what we have in Dr. Ron Garry. Dr. Ron has been a frequent presenter at Lifelong Learning, and I'm told actually is the personal physician of many members right here within Gray Oaks. So let's do it justice by reading some of the highlights quickly of his biography, and then we'll get him center stage. Dr. Ron was born and raised in Long Island, New York. He was a scholar in medicine at Stony Brook School of Medicine and graduated with added distinction in research. He then moved to Boston, where he did his internal medicine training at Beth Israel Deaconess Medical Center and the Harvard Medical School. While at Beth Israel Deaconess, he received the Dr. James Tullis Award for Intellectual Growth. And Dr. Garry did his geriatric fellowship at Harvard Medical School, and upon completion joined the faculty at Beth Israel and the Harvard Med School. He's published 2 books, Living Independently in Your Later Years and Living Better, Living Longer, The Secrets to Healthy Aging. Dr. Garry serves as medical directors for 2 assisted living facilities and a home care company. And he is currently the subsection chief of geriatrics at NCH, and was previously appointed by Governor Jeb Bush as an expert to the Agency of Healthcare Administration. I should mention he's triple board certified: 1, American Board of Hospice and Palliative Medicine; 2, certified geriatrics; and 3, certified by the American Board of Internal Medicine. And then finally, you might find it interesting to know that 7 times, 7 years, He made the U.S. News and World Report list as a top geriatric doctor. 7 times he made the list as top 10 doctors in Naples for internal medicine, and 7 times won the Patient Choice Award. Ladies and gentlemen, Dr. Ron Garry.
Well, thank you, David. Always a pleasure to be here. It's always a little bit interesting to give a talk when you don't actually have an audience in front of you. But I wanted to talk a little bit about what's on everybody's mind, and it's coronavirus. I'm going to just give the facts. You know, unfortunately, our society has kind of got into the age where everything has become political. And I'm just here giving facts. Don't shoot the messenger. But COVID is a real important topic. You know, this is the second pandemic in my lifetime that we've had to deal with. The first one was, you know, HIV. And then this one is absolutely much worse because it's a viral illness, which is much more difficult. So you always start off with a joke. If the coronavirus is so dangerous, the pilot wouldn't be flying. That's our pilot. And obviously you can see, you know, early on the fears we had with the coronavirus and how infectious it was. And I got to tell you, this is a very infectious virus. I've never seen anything like this. It's just so easy to spread. And that's why we all have to be so careful with regard to that. When we talk about what a virus is, in my early years when I was at Stony Brook, I did marine biology research. And I was fortunate enough to actually discover the first marine virus. And so viruses have been kind of near and dear to my heart. And they're simple killing machines. They don't have many parts, not many things can break, and they're basically everywhere. But it's hard to believe in the 90s, people actually didn't think there was viruses in the marine environment. And the marine environment's loaded with viruses. So they're microscopic organisms and they're everywhere. They're associated with diseases, but they don't have to be. So one of the viruses you'll hear with farmers deal with regard to oranges, there's viruses that affect tomatoes. And then their genetic material is either RNA or DNA. And DNA viruses tend to be more stable because they have they have more proof mechanisms, so they get copied more efficiently. RNA viruses like influenza, like COVID, tend to mutate a lot more. And one of the things you've heard about and read about is there have been a lot of mutations with regard to the COVID vaccine. They're the most abundant biological entity on Earth. And some other examples you've heard of is rabies, herpes, Ebola, SARS, MERS, HIV, all examples of different viruses. And so I don't want to get into too much detail, but I just think it's important to have a good understanding about what a virus is, just because the simplicity is why they're so difficult to treat. So a virus attaches to a receptor, and then it gets encapsulated within the cell. And then it breaks up into its genetic material and its proteins. And it uses your machinery to replicate its protein, and it uses your machinery to replicate its RNA or DNA. Then it gets put back together and then it leaves. So one comes in and hundreds go out. And this is the very nature of it. How do you stop it when it's using your own machinery? You can't stop it here. You can't stop it here without hurting yourself. And that's the intrinsic difficulties with regard to viruses. So when we look at the SARS virus or the COVID virus, it binds onto this ACE2 receptor. And many of you have heard about ACE receptors because many of you are on ACE inhibitors, lisinopril, Prinavil. These are common medicines that we use to treat hypertension. But the virus basically gets into the cell, and the same process happens where the RNA gets replicated, the proteins get replicated, and then it gets put back together. We think this is where remdesivir works. And there are some drugs that I'll talk about that potentially can work over here at the ACE receptor. We don't really have RNA and DNA dependent polymerases that don't affect us. And you could see we have targets at the spike, at the receptor, and then maybe an antiviral. And remember, remdesivir was not made for COVID. It's been around for many, many years. And so there is Lilly has a drug called a soluble ACE2. And what it does is you would inject this into somebody and it binds onto the spikes. And it prevents all the spikes would be taken up by this medicine, and thus it can't bind on to the cell and get in. This slide wasn't in my talk on Monday, right? And then on Tuesday, they came out that this drug may be coming out, and thus we put it in. And that's how quick this, COVID is moving. I last updated this talk at 3:45, today. And that's just how, quick it moves. So when we look at the ACE levels in the elderly, ACE levels actually go down with aging. And so it takes a higher bolus of COVID to affect older people. So younger people are much easier to get infected. But we think that the lower level of ACE is the reason why older people have such profound illness from the disease. And I always like to point out how infective this virus is. So the average person who has influenza, the flu, gives it to 1.5 people. The average person who has coronavirus gives it to 7 people. So one gives it to 7, and then each of those 7 give it to 7 more. And you could see how difficult this virus is to get under control. So we think that this ACE level is why the older people have so much inflammation. And it's really the inflammation. Our immune systems go crazy and we can't regulate it. And they end up causing damage in the lung, in the heart, in the brain. And so I think everybody's familiar with the symptoms of COVID. But I wanted to point out that fever and chills, cough, and shortness of breath are the ones that are most likely to get you in the hospital. But I'll tell you, one of the biggest complaints I see is fatigue. When I hear fatigue, I do a COVID test. And I got to tell you, 7 out of 10 times I'm finding COVID when they have profound fatigue. Not chronic fatigue, but I was fine on Monday and Tuesday I have no energy. And just like any other virus, we see problems with muscle and body aches. They get headaches. And what's really classic for COVID is they get a loss of taste and smell. We don't see this in other viruses. It's quite dramatic. And it happens early on, and it's a good sign that you have something going on and you need a COVID test. We also get sore throat, we get congestion, we get nausea, vomiting. And when my patients call me now with diarrhea, I do a COVID test. And it's crazy because for 20 years, I've been getting tons of phone calls for diarrhea. But now when we get it, I do a COVID test. I just did one today at Moorings Park on somebody who had diarrhea, and the COVID was negative. But it's become so important to diagnose because we want to stop the spread of it, and you want to, quarantine them as quick as possible. And when we think about how it presents, this is the irony of this. You could be 96 years old and get the sniffles, and you could be 50 years old and end up in respiratory shock. And COVID has coined this term called HOPI hypoxia. Hypoxia means low oxygen. So people feel okay, they look okay, but their oxygen level is low. And this is unique to COVID, and it's probably going to be something that doctors talk about forever. But the mild disease, can be runny nose, can be no symptoms, and can be a mild pneumonia. The severe disease is shortness of breath, low oxygen, and it tends to be about 50% of the lung is involved. And a critical disease tends to be this inflammatory state that just goes crazy. They tend to end up in respiratory failure. They end up in shock, multi-organ failure. It's only about 5% of the cases. This is very age dependent. If you end up in this case, you've got a long, difficult road ahead of you. All the deaths occur in the people who have critical illness. So if you just have sniffles, you're going to do fine. And so what are the risk factors for the severe illness? Age, and I'll talk a little bit about that. Having a prior stroke, having diabetes, chronic lung disease, chronic kidney disease, and cardiac disease. And this is somebody who's had a prior heart attack, heart failure, because we know COVID tends to cause a lot of inflammation in the heart. And so when we look at what happens with older adults, 8 out of 10 COVID deaths are reported in the US in those over the age of 65. And I always like to say this is a geriatric disease, and I claim it for everything. Heart failure is a geriatric disease, stroke is a geriatric disease, heart attacks is a geriatric disease. This truly is a geriatric disease in the sense that if you're older, you're the person who's going to die from it as opposed to the younger people. Younger people could have no symptoms at all. You see every day the football players or the baseball players who were getting it, and they really had almost no symptoms with regard to that. When we look at the risk factors, asthma at first was thought to be a very strong risk factor. It turns out it's not a very big risk factor, but it increases your risk, 1.5 times or 150%. Hypertension. And when you look at the age of 80% of the population has hypertension. And so you could see how older people at higher risk, they have comorbidities such as hypertension. But look at obesity. And so this is a BMI over 30, body mass index, 300%, just like hypertension. Diabetes, also 300%. Chronic kidney disease is 400%. And then severe obesity is 450%. If you have two conditions, hypertension and asthma, obesity and hypertension, 450%. And if you have more conditions, upwards of 500% increase. And so if you see yourself into these categories, you're the type of person who has to be extra careful and really not try to take any risk with regard to this virus. And so when we look at the hospitalization and death rate, you could see younger people do very well. They don't die from this disease. It's rare. And so well over 99%, 99.6% of young people do well with this disease. The 30 to 40 range, they still do okay, but the rate goes up compared to this 18 to 29, which is probably when most of us are at our fittest. When you get up into the 75 and older, you see a marked increase, eightfold. And then when you get into what we call the oldest old, which is 85 and older, you get up into this 13 times. And you can see that the chance of death is 630 times higher than in somebody who's 18 to 29. And so protecting the elderly really become the key to preventing deaths with regard to COVID. So race plays a role. So African Americans have a much higher rate of getting the disease and also being hospitalized for the disease, and they have a higher rate of death. And Hispanics, a little bit higher rate of the cases, as well as hospitalization. And for some reason, the death rate doesn't seem to be dramatically increased. And so race plays a role, and ACE levels are different from different races, and it may be the reason why we're saying that. But this again just illustrates the marked increase that we see in mortality in the older people. And so if you had to draw a line, it'd probably be somewhere around here where you really need to be, more careful with regard to this disease. And you can see this is 513 deaths per 100,000, which when you see death rates being reported, they're usually reported per 100,000. I just wanted to point out that this is not an American phenomena. And so when you look in Geneva, the older people had a much higher risk of dying. When you look at England, it was even much more dramatic than we had in America. But you can see as you get younger people just do well with this disease. It's the older patients who do not do well with this disease. One of the things we see is we get this hypercoagulability, and their blood just gets sticky. And that's why you hear, reports about taking aspirin, trying to make the blood a little bit less sticky. We get an increase in D-dimer, which is a marker of the clotting system going crazy. And we could actually get prolonged prothrombin times. So anybody who's on Coumadin, this is what we measure. This is the INR that you may be familiar with. And so we know that, COVID is activating our immune system. And so this led to COVID toes, where people had modeling of their toes, white and purple lines. If they had catheters in the hospital, they clotted off. These are the ways we're giving medications, and we weren't able to get the medicines in. They were having heart attacks because their coronary arteries were clotting off. And then we also saw large vessel strokes, into the brain, the MCA and other vessels, which then lead to a stroke. And these are devastating. I wasn't going to talk about it too much today, but there's this chronic conditions we're seeing associated with COVID, where people say their brain's not the same, their energy level doesn't come back. And there's no question, COVID is creating chronic disease as well. When we look at the age distribution here in Collier County, and so this was just updated at 3:45, you could see that we've done a very good job at limiting this disease to younger people. And you could see how few compared to the overall cases have been in the older people. This is about 350 out of 14,000 cases or so. We've done a good job, and the median age in Collier County is 41. Earlier on, it was 38, 39. It's been creeping up. But if you want to prevent people from dying, these are the people you have to prevent from getting this virus. And so I present this in a non-political way. And so whenever there's something new in medicine, we learn. And this was the executive order from Andrew Cuomo in New York. And you could see that no resident shall be denied readmission or admission to the nursing home solely based on a confirmed or suspected diagnosis of COVID-19. Nursing homes are prohibited from requiring a hospitalized resident who is determined medically stable to be tested for COVID prior to admission or readmission. And as a geriatrician, this is just crazy, because in order to stop this from spreading in a nursing home, you need to know who has it so you could quarantine them. And I think what happened early on, there was the fear that the hospitals were going to be overrun. And the older people were taking up the bed, so there was this push to get them back to the nursing homes. But you need to protect the older people, and you always want to COVID test them so you could quarantine them to help limit it to spread. And this is one of the reasons why New Jersey had the same order as well. So this was updated on November 11th. You could see that the death rate per 100,000 going from different states. And so New Jersey, New York, which had this executive order, Massachusetts had a similar one, Connecticut did. And down in Florida, we're much lower. So we've done very well with regard to the death rate. We haven't done well at stopping COVID. But what we did was we protected the older people in the nursing homes. And I'm not going to tell you that this was not without consequences. There was elderly people in nursing homes who did not see a family member for 4 or 5 months. And they had no social contacts. And so there is, there's no question, there's no free lunch here. But if we're trying to save lives, what you do is you save the older people. And so this is what's called the 7-day moving average. It comes from NCH data. I have no control over the ugly red color, but you could see this is back in March, right? This is the peak we're all familiar with in July. And then we've been steadily rising since then. And so in my mind, we're not on fire like we were in July, but I'm worried that with the holidays approaching, that we may become on fire in a very short period of time. And I see it in my patients, they're just not hunkering down as much. One of my patients last week was planning on going to a brunch with 35 people. And I mean, I'm almost lost my mind. I mean, it's silliness. But, we're all free people and we make our own decisions. But I'm still shaving my own head. I haven't gone to a barber yet. So when we look at, again, this was updated today. you could see that the cases that we're getting, in the state of Florida, we're averaging probably about roughly 6,000 a day. And interesting, this is about the same rate of cases that Michigan's getting. And you could see if you're locked down, not locked down, COVID is just so difficult to prevent. If I was a president, if I was the governor, I don't know what I would do. This is just such a difficult virus to take care of. But the nice thing is the cases are here, but look at our death rate in the state of Florida. So as the cases have gone up, our death rate continues to go down. And some of this is we have a little bit of better treatments for the disease that I'll go over, but our treatments are still rudimentary at best. And I think the reason why we didn't see the death rates go up with regard to the cases is because we're still doing a good job at protecting the elderly. At any assisted living, at any nursing home, I could get a rapid COVID test right now and have results in 15 minutes. We couldn't do that in July. And so we're in a good position to protect our elderly. Much harder for my mobile patients who aren't in assisted livings to get a rapid test. They're available, but it's a little bit more difficult. So when we look at the NCH experience, if 100 people got COVID in Collier County, 93 are managed at home. 7 are hospitalized, and 3 get very ill. And if you end up in the ICU, 30% die. But what's alarming is 3,900 to 4,000 per 100,000 people are dying. Well, for the average for the state of Florida, it's probably 77. You got to take this cautiously because we're a small county and we don't have a lot of data. And you get 5 or 10 deaths and they can skew the data dramatically. And again, this isn't age matched. And so in Miami-Dade, there are so many more younger people who have COVID than there are in Collier County, just to make up of the population difference. So I'm going to talk about some of the treatments, but just to go over them at a 30,000 foot view. Everybody's heard about remdesivir, promising for hospitalized patients, promising enough that I'll show you some of the data. Monoclonal antibodies, which is super, super promising. Bamlanivimab is the Lilly drug, and then there's Regeneron. I think these will have a role within the first 3 days. I think once you start making your own antibodies, which is probably day 5 to day 7, this probably won't offer very much. And that's where rapid testing becomes important so you can get these drugs. Regeneron right now can be given at Sarasota Memorial Hospital. It's got to be done in a trial, but our patients that I diagnose early, I recommend strongly that they go up to Sarasota Memorial, especially if they're higher risk. Convalescent plasma is what we're doing at NCH. So convalescent plasma is somebody has COVID, we take their plasma, which has the antibodies in it, and then we infuse it in. And we could actually measure the titers, and we can tell who has high antibodies to COVID and who has low antibodies. And at NCH, we give high titer, and we have a ton of it. And so if we got a second wave, we have more than enough plasma. The problem is the data is still not very good. It's a little insufficient at this point. And so, the guidelines basically don't take a stance on it, but they leave it up to the individual hospitals. Hydroxychloroquine, there's really, the studies have come out. There was some hope early on. It does not appear it offers anything. And so this is not part of standard treatment anymore. Interleukin-6 inhibitors, this was very promising. We thought this would turn off the immune systems. NCH was involved in one of the studies with Mayo Clinic, and it looks like it's actually not doing anything. And so they're not actually doing that anymore. Ivermectin is a parasitic drug that we give for worms that showed promise, but it doesn't appear to be doing anything. And then the soluble ACE2, which would block the virus from getting into our cells, is very promising as well. And so this is the data for remdesivir. This is an ugly, ugly, ugly slide. Um, but the point is, when we looked at it, 5 days was as good as 10 days. And so most of the time we do 5 days. The lighter colors are people who are being discharged to home. And you could see more people being discharged to home who got 5 days of remdesivir than standard of care. And you saw this in all the different treatment arms. So remdesivir has been pretty much standard of care, but again, it's given in a hospital setting. It's a 5-day course. It costs about $2,300. But it's an infusion, and so you have to be in the hospital to get this. Is it possible that eventually it could be given as an outpatient? Potentially, but right now it's only be given to people who are moderate to severely sick related to COVID. So Regeneron is it's a combination of 2 monoclonal antibodies. And what they did was they took somebody who was in China who had COVID early, and they actually just took the antibodies and they replicated it. So it's a man-made antibody that came from somebody who had COVID. Currently, it's given to non-hospitalized patients. It's got to be given early. The studies, I think, are going up to 7 days, but my gut feeling is probably in the first 3 days. So I've been sending people to the CenturyLink up in CenturyLink Arena in Fort Myers. They go up there, get their rapid COVID test, and then if they're positive, then we have a discussion about whether they drive another 30, 40 minutes to go to Sarasota Memorial. There's hope that this is going to be available within the next 30 days, and whether it can be given at an infusion center as an outpatient would be wonderful. We're still working out the optimal dose with regard to it, but it's a single infusion. And so you would go in, get the dose, and because it's blocking the virus from getting into the cells, it can jumpstart it until you make your own antibodies. And we also saw in the studies that it decreased the viral load. Steroids, pretty much anybody who has COVID, who's symptomatic, and more on the moderate side, I'm giving dexamethasone. It's 6 milligrams per day, up to 10 days. Definitely, I'll show you some data about hospitalized patients. They're recommending not to give it in asymptomatic people, and the asymptomatic people are people who don't require oxygen. It appears that the real advantage for this is on the lungs. And so people who need oxygen or their oxygen saturation has gone down get the advantage. And so that's what we'll do. If I see a pulse ox is dropping, we talked earlier about the hypoxia, you have to check it because people won't know that their oxygen level is low. And you could use other steroids as well, prednisone, methylprednisone, hydrocortisone, but dexamethasone has been the one that's best studied. And the survival benefit appears to be greatest among patients who require, ICU and who are on a ventilator. But almost 30% of participants in the dexamethasone arm died within 20 days of enrollment, compared to 41% of the standard of care alone arm. And that's a marked improvement, in outcomes by giving dexamethasone. And this is kind of what you see. The usual care, this is survival curves. Being lower is better. You could see the advantage of getting dexamethasone with regard to oxygen alone, whether you're on an ICU, and if they didn't get any oxygen, we don't see as much of a benefit from it. And again, we'd give you oxygen if your oxygen saturation, if you became hypoxic, came down. And that's why we tend to think it's for ICU management or people who's become hypoxic and need it. And so the soluble recombinant ACE2, this is, it's fascinating because it binds on to the receptor that we talked about earlier. And if it's bound up, the virus can't get into the cell, and then it has no effect on you, and it can't replicate. And then it also combined onto the S protein or the spike protein of the coronavirus. And if it's all taken up, it can't get in. And so this would be something, somebody tests positive, they get fatigue, they get a cough, they get a COVID test, they get the soluble recombinant acin receptor, and boom, there are case reports of people being better within hours. And so, we may not be able to, while the vaccine's kicking in, while we're waiting, we may have solutions for people. And if we prevent this from going, this patient is likely not to be infectious, for the same length of time, which means cases will come down. And so you can see how we're tackling this virus in so many different ways. And from a healthcare professional, to think in less than a year we've developed all this is just fascinating. It's just amazing how far we've come in such a short period of time. And so these are just some things that I pulled from the literature. After the first injection of the ACE2 receptor blocker, a marked reduction of angiotensin II was observed. This was followed by a reduction of inflammation of cytokines that are critical for the pathology that we see, and ferritin and C-reactive proteins are markers of inflammation. The data clearly demonstrates that the virus disappeared swiftly from the serum and from the nasal cavity in the lungs. This can take a 14-day infection and potentially make it into a 1, 2, 3-day infection. And again, that's less people who then could spread it to other people. So when we did this, there was a concern that we wouldn't make our own antibodies. And it turns out that the initial exposure before you get this was still enough for us to make our own antibodies and thus, make us immune. And if you think back in April, May, June, we didn't actually know whether the antibodies we made would actually prevent us from getting it again, right? We now know that it appears that that's the case. We also didn't know whether you could get it again and how long the antibodies were going to last. We still don't know that, right? We don't know if when a COVID vaccine comes out, is it a once a year? Is it a once in a lifetime? But we'll figure that out with time. So for people who get mild disease, zinc is what we recommend. Studies have been around since 2010, looking at zinc in other coronaviruses. Remember, there's hundreds and hundreds of coronaviruses. Almost everybody who's on this call right now has had a coronavirus infection in their life, right? This is just a variety of a coronavirus. And so there's some data that zinc can help. So theoretically, sucking on zinc oxygens during the early stages of COVID may reduce symptom severity and the duration of the illness. It's really not been proven. There's really not a downside. And so somewhere between 60 and 75 milligrams a day, it's not related to deficiency of zinc, because it's pretty rare to be zinc deficient in this country. And so when I think somebody potentially have COVID, I put them on zinc right away. I put them on Pepcid, which is an acid blocker that has some promising, and I put them on it if they're on the younger side. Pepcid sometimes may have some cognitive issues in older people who are frail, so I'm a little bit more hesitant. So I tend to individualize it, and that's why I didn't give a slide on that today, because I didn't want some 90-year-old who may have some memory difficulty just throwing themselves on Pepcid. So vitamin D is interesting. There's a high rate of vitamin D deficiency in those who tested positive for the virus. That doesn't mean that there's a risk associated with this. Higher rate of vitamin D deficiency in those with more severe disease. In my patients, I check a vitamin D once a year anyway, and we treat the deficiency. So most of my patients aren't deficient in it. Some small studies showed improvement. And so I check if I've had a vitamin D level in the last 3, 4, or 5 months on my patients, and they had good levels, I don't give them vitamin D. If I don't have a recent vitamin D, maybe I saw their physical was 9 months ago, then I put them on a 2,000 of vitamin D. But the bottom line is we should be treating vitamin D deficiency anyway. And a lot of things in medicine seem correct that turn out not to be the correct. For years, people who had higher levels of homocysteine had a higher risk of heart disease, stroke, Alzheimer's disease. And for 20 years, we treated homocysteine. And then finally, we realized that treating them didn't do anything. And so homocysteine is a risk factor for Alzheimer's disease and strokes. But it's more complicated than that. And by lowering homocysteine, it didn't make a difference. And so what's the untold story of COVID-19? I alluded to this earlier. It's the lockdowns led to social isolations. And this is kind of the approach we did where we protected our seniors here. And there was cost. And it was cost. I see a lady at Orchard Terrace at Mornings Park. She has a very close family. Every time I go see her, she asks me, why doesn't my family come visit me anymore? And she's got Alzheimer's, so you try to tell her why, but she forgets. And it's heartbreaking to hear. And now at least the facilities can test and they can let family members in, but that wasn't around in June, July, August, but now we can. Patients went through medical illnesses alone and even died alone, right? This was never the case in our country. We're always with our loved ones when they need us. And so it really created this thing where people in the hospital and family members were trying to FaceTime and call them, and just seeing your loved one's face, tells you so much. And not being there, it was devastating for a lot of people. 32% of people who have been diagnosed with breast cancer reported a delay in care. And the rates of screening of all cancers are down. And I'll show you some slides for that. I like to joke that COVID has cured cancer. And obviously it's tongue in cheek because the cancer rates are down. And it's because people aren't going to the doctors. They're not getting screening. And we're going to find these. But unfortunately, when we find them, we're going to find them at a more advanced stage, which is never good. And then loneliness and social isolation, which is a huge problem in seniors already. Is an epidemic level. As you age, one of the most depressing things is people you've known for 40, 50 years, die. Your family members die. And then to be placed in an assisted living and not be able to have any visitors, the ramifications of that are are still untold, and we're going to find them out. So when we look at a healthcare, this is in billions. So this is $7 trillion, lost GDP, $7.5 trillion. Health loss, premature death, 4.3 trillion. Long-term health impairment, 2.5 trillion. Mental health, 1.5 trillion. And so I'm sure many of you saw this when it came out in January. It was picked up by the New York Times, the Wall Street Journal. So the total cost when this came out, which was in October, was $16 trillion COVID, $16 trillion. Yes, I said that right, is what COVID has cost us. It's been fascinating, 90% of the annual GDP. And so it's been an expensive disease in multiple different ways. When we look at this cancer screening, in March, mammograms went down by 50%, April, 84%. Then it started to pick up in May. June was up a little bit, and then July it was still down. Colon screens, colonoscopies, 41%, April, 75%, May, 49%, 24%, July, 37%. I mean, this is a huge deficit of people who have not got their colonoscopies, and hopefully they'll catch up. Same thing happens with regard to lung cancer, screening down by a half, and the same thing with prostate cancer. And so when you actually look at the incidence of cancers, they've gone down because we're not looking for it. And obviously people were scared to go to healthcare. They were worried about doctors' offices. And you can see also for biopsies, in May, 61% down, decrease in breast biopsies, colon biopsies, lung biopsies, mastectomies. These are treatments for colon cancer. These cancers didn't go away. They're gonna show up, and we're gonna have to pay the cost of that. So these are the current vaccines that are being developed. I show this slide to show you how many there are. Our government is taking the top 10 and it's paid to have them made. And whether they work or not, we're we're being able to mass produce them. And so that's why the Moderna vaccine, which I'll talk a little bit about, already has 125 million doses. The Pfizer vaccine, which you've all heard about on Monday, there's 25 million doses. This is unheard of. You never make a product before you know it's effective. This really is probably going to save 6 to 12 months. And this was that Operation Warp Speed. And we're all paying for it, you know, by subsidizing these companies. And ultimately, we're going to get the rewards from this. So the Moderna vaccine, a small study, was published in the New England Journal of Medicine in September. No serious adverse events, but these aren't the easiest viruses. People get headache, fatigue, myalgias, chills, injection site pain. When we rev up your immune system, you get these symptoms, whether it's from the flu shot, from the tetanus shot, the shingles shot. And these are, you know, compared to what COVID can cause, these are quite minor. You'll hear talks about delaying vaccines for preventative studies, because when we do most of the vaccine studies, we're doing to make sure you develop antibodies. And we assume that the antibodies, we compare them to people who have COVID. If you have antibodies at the same level of people who have COVID, they're going to be protective. Prevention trials would take another year. And if we delayed it another year, you know, it's, you know, probably another couple 100,000 Americans would die. And none of our other vaccine studies have been this way. So when we look at the Moderna vaccine, you could see in the different age groups, even the older subset, they got a good response to the vaccine. And so the vaccines appear to be working in young people as well as in older people. And that's really good. The problem with these vaccines is that they're messenger RNA vaccines. And these vaccines are the first messenger RNA vaccines we've ever done. And they need to be kept frozen, you know, minus 70 degrees. And so nobody really has storage for this. And so developing the infrastructure to distribute these is quite difficult because it's got to stay at minus 70 degrees. And so how do you ship it? How do you get on a truck? And this is why the government has put it on to the military, you know, with their logistic capabilities to kind of figure it out. And so this just came out on Monday. And so this is the Pfizer vaccine. And they actually did two vaccines. There's B1 and the B2. The B2 is the one that is going to be the one that's coming out. And you can see this was checking out the different doses of it. And, you know, you got wonderful immune responses from it quite quickly. And by the second shot at the end of a month, you know, people had antibodies and, you know, they're going to be immune. And the Pfizer vaccine looks like it's going to be 90% effective. And, you know, it's quite incredible. Our threshold that the FDA defined to approve a vaccine was 50%. And when we talk about herd immunity, you need a large percentage of the population to get it, either getting the infection or getting, you know, vaccinated and developing, you know, immunity from the vaccine. And if you have a 90% effective vaccine, you don't need as many people to get the vaccine. So in June, about 75% of Americans said they would take the vaccine. And by the time we were done with our election cycle, it was under 50%. And if it was only 50% effective, we'd be in trouble. 90% effective, and then hopefully we could work on that number and get it back up to 70%. Then we should be in good shape. You know, New York City has what, 30% of the people have been exposed to the virus. So a place like New York City would be able to develop herd immunity fairly quickly. And so this just came out today. This is from the state of Florida, their draft vaccine distribution plan. So this is, you know, not written in stone, but they want to basically start off giving it to hospitals and healthcare workers, long-term care facilities and their staff. And most of the residents who get it at a long-term care facility are getting it from the staff. So you have to vaccinate them. The first responders, the police, the fire department, the EMTs, and then we start doing mass vaccination, for older people who are higher risk. And then we move down to, lower risk people for this. And, it depends on how quick, the vaccine is going to be available, which vaccine. There may be a chance that we have 3 or 4 vaccines, and we won't know which one is better for, a year or two, potentially even longer. But the state of Florida is already developing this. Obviously, there's one for the country as well. So what is the future? You got to continue with social distancing. And this really is the key. A mask helps. But if I had COVID and you want to spend a couple hours with me and you're within 5-6 feet, you're probably going to get it. And so social distancing really is the key for this. Obviously, you want to wear a mask, but if you're 12, 15 feet apart, you don't really need a mask. And social distancing is the key. If you can't social distance, then you wear a mask. You want to get your flu shot, but it's been amazing. I've had 2 respiratory infections in my practice that were non-COVID since April, because everybody's washing their hands, they're wearing masks, and it's just amazing. If we continue when this is all said and done, and keep washing our hands, keep using, the alcohol washes, we're not going to get all the respiratory infections that we all used to get 2, 3, 4 times a year. Vaccines are going to be available soon, and soon is probably definitely within a month. I'm a big proponent of getting tested early. The real 2 places to get rapid testing without going to the emergency room are Advanced Medical. They do charge $150 cash. And then the CenturyLink Stadium up in Fort Myers, you get the results, same day. When I send it to Quest, which is how I test myself, it's anywhere between 2 days, 4 days. In June, July, sometimes it was taking 10 to 14 days. But right now it's probably about 2 days. But last I checked, Quest was not running it on the weekend. So if I did a test on a Friday, Saturday and Sunday doesn't count as the 2 days. And so it could be, Monday, Tuesday, Wednesday before I'm getting. You want to consider monoclonal antibodies as soon as possible. I would start zinc if you've been exposed. If you're young and healthy, I would get Pepcid, which is famotidine. It's over the counter, 20 milligrams twice a day, and dexamethasone for anybody who is short of breath or who has a low oxygen level. All right, so why am I showing you a map? And so this is the route for the Boston Marathon. And the Boston Marathon starts in Hopkinton, which is a nice rural area in Massachusetts. And it comes through Framingham, which is where the Framingham Heart Study was. It comes along Route 9 through Natick and Wellesley, and then it comes through Newton. Right about here, you're going through Heartbreak Hill, which, if you're from Maine, Michigan, probably, not a big hill, but it's where it's located around mile 20. And we're coming into downtown Boston. And this is where we are. We're at like mile 22. And it's crazy now to get COVID and to be irresponsible, because we can see the finish line. The finish line's in front of us. And we're getting these patients who are getting COVID, who are getting chronically ill. And their lives may never be the same. And so as the holidays approach, what we're recommending for our patients is that anybody who's get together, everybody get tested. And whether it's a rapid test or whether it's going to Walgreens, CVS, and doing one of the ones that take 2 to 3 days and doing it ahead of time. At mile 22, 23, you don't stop the marathon, you finish. And that's where we are right now. We want to finish this. You do not want to get this. This is a bad virus. I've seen 50-year-olds who have been devastated and their lives will never be the same. And I've seen 96-year-olds get the sniffles. It's not predictable. If you're 18 years old, you're going to do fine. But if you have some health issues, you really want to hunker down, and we're almost there. I mean, within the next month, I suspect we're going to be starting to give the vaccine. We're going to be giving these monoclonal antibodies. We're going to be giving the ACE blockers. I mean, we're almost there. We just need to finish this before we get sick. This was the view one day coming back from Marco Island, going into work. Not so bad. But with that, I'll go ahead and take some questions if there are any questions. I feel that if I bored you, I can't see the audience when I'm talking. So if everybody was sleeping, I apologize.
Oh, bravo. Thank you very much. So I think everybody knows the drill, but if you're new to Zoom, you just hover your mouse, your cursor down below where it says chat. You can open that chat box and then go ahead and type your question.